It's another Friday at RP. How's it going, everybody? This week, today, Friday, we have got a few cases on the board today. We've got some PRP procedures. Sounds like it's going to be the hand, maybe the wrist, I don't know yet. And then we have a cervical case with some foot ankle pain as well. The patients have come in from out of state because of travel. They weren't able to get here until today. And so we're gonna be doing our physical exam and evaluation this morning, and then following up that with our procedure. So I don't know exactly what we are treating today, but we'll keep you posted. And then Dr. Myers also has a PRP facial today. And so I don't know if we'll be getting any footage of that procedure, but she's also got that going on, which is always exciting. So that's our day, and I hope you guys enjoy this week's episode. Let's get it. All right, so we just finished our first procedure of the day. So this patient is having some right-sided hand pain. She is a body worker, a physical therapist, and with her job comes a lot of manual work with her hands. And so because of that, her right hand in particular has been having some issues basically in the thenar eminence, which is gonna be basically your thumb, and then in some of the proximal carpal bones and ligaments that are supporting in there. And so she'd had a few steroid injections, which actually made her pain worse, which, I mean, we commonly see that with a lot of these soft tissue injuries. When we have ligament and tendon issues, steroids into that stuff just generally does not do as well. And we can sometimes see instances where patients get a lot worse because the steroids can degrade some of that tissue that it's injected into, especially if you have multiple of them. And so she came to see us for some help with that pain. And so our physical exam really showed that she had a little bit of instability of her first CMC joint. And so the capsular ligaments around the first carpal metacarpal joint were a little unstable, and then also tender and inflamed, which can also signify that there's some micro trauma to it, some ligament laxity, whatever we want to call it. Then we also had some tenderness and pain with the other volar ligaments, the supporting ligaments on the carpal row. So specifically the scaphocapitate ligament and then the scapholunate ligament. These ligaments help to provide stability for the actual carpal bones, and when they get whether they're inflamed, whether they're mildly degenerative, whether there's some micro tearing, what we can see is we can see pain when those ligaments are under stress. It's a very common thing with ligament pain is when they're under load, under stress, they get painful. And so we obviously treated those as well in our injection, obviously under ultrasound guidance for the most part, but there's a few things that it's very superficial, bony prominences that we just pepper along that insertion. And the last thing that we found, which we found we suspected something was going on with the flexor digitorum superficialis or profundus tendons based on our physical exam. And then under ultrasound, we actually found a small little tear in the flexor digitorum profundus tendon. And it seemed like it was not sliding as well when she was doing her finger flexion while I was looking at it under ultrasound, which is a dynamic test that we can do under ultrasound. And so we injected PRP into what looked like a tear, a small region of hyperechoic that kind of goes across and through the actual tendon. And then we also hydrodissected the tendon and the tendon sheath to try and allow it to slide a little bit better. So that was our first case of the day. I'm gonna get some water, and then we're gonna get on with our second case of the day. Alrighty, Alrighty, so we just finished our second procedure of the day. So what we did today for this gentleman was he was in an accident in early February, which caused some neck pain, some radicular pain, and then a little bit of burning and paresthesias in and around the thoracic cervical spine, and also down into his arms. Now he has worked with a few other providers, some physical therapists. He's had dry needling. He's had other treatments done, and has been in really good hands. And most of the central cord symptoms that he is having have resolved. And so he's no longer having a ton of radiating pain down into the arms or anything like that. But he is still having some symptoms, especially when he's in a slight cervical flexion position. And so we reviewed his MRI, which showed some mild central stenosis, which on its own is probably not causing a huge amount of symptoms in that neutral position. But because when he goes into flexion, basically the ventral or the front side of the spinal cord is going to get compressed a little bit because of the disc bulges that he has in the cervical spine. And so our approach today, this is phase 1 of 2, and hopefully we don't have to move to phase 2. But phase 1 is basically today we performed a cervical erector spinae plane hydrodissection. And so we went up to the transverse process of C7 and then injected deep to the erector spinae muscle group in order to try to bathe the dorsal root ganglia and the medial cutaneous branches in that region to try and just calm down some of that nerve inflammation. And then the structural component that we're going to work on is improving the posterior stability of the spine such that we get more of that C shape, so our cervical lordosis, as opposed to the loss of cervical lordosis where it flattens out. And so a lot of that is, all that stability comes from the capsular ligaments in the back of the neck, so around the facet joints. We have the nuchal ligament, and then all the little stabilizing muscles, so that things like the multifidi, as well as some of these suboccipital muscles. Now, we also treated his suboccipital muscles up on the suboccipital ridge, and my thinking behind that is when we have dysfunction in those muscles, what can happen is you can actually get a small minor collapse of the dura up at that level, because there are actual fascial attachments from the suboccipital muscles down to the dura. And so if those muscles are not functioning the way that they should, they are not firing appropriately, their tonicity, either they're locked long or locked short depending on what's going on, what we can have is we don't get as much tenting of the dura in the upper cervical region. And so because with him we are trying to improve how much fluid flow we are getting in the CSF, so that way the spinal cord has nutrition and we're not having any of that compression from the central stenosis. That is our goal and our approach there. And so we're going to track him over the next week, and then potentially next week we'll do phase 2 of our treatment, which may include an epidural, it may include nerve root hydrodissections, or it may just be an erector spinae plane hydrodissection. We don't know yet. We are going to base that determination on how he does this week prior to next Friday. So that is our second case of the day. I think that's all we have left for the day here, so I'm gonna get to some food, but I hope you all enjoyed watching this week, and like, comment, subscribe. Let me know what you liked, and we'll see you later.